Is it tacrolimus? The side effect? Yes. Okay, is it tacrolimus? The side effect of tacrolimus is hyperkalemia. Okay, calcineurin inhibitor, tacrolimus, cyclosporin inhibit the transcription of interleukin 2, inhibit the transcription of interleukin 2 to reduce T lymphocyte activity, are important component of chronic immunosuppression following a solid organ transplantation. Although these drugs are generally well tolerated, they have numerous adverse effects must be monitored. They have numerous adverse effects must be monitored. Nephrotoxicity calcineurin inhibitor have vasoconstrictive properties that can lead to reversible acute injury. That can lead to reversible acute injury usually in the setting of elevated blood levels of the drug or slowly progressive CKD that is typically irreversible. Associated electrolyte abnormalities are also common, including hyperkalemia, hyperuricemia with increased rate of gout. Hypertension, the vasoconstrictive properties can also cause hypertension both by triggering increasing sodium retention by the kidneys through the increased arteriolar peripheral resistance. Nephrotoxicity, these effects may be due to low levels of vasoconstrictive maybe vasoconstrictive cerebellar ischemia. Tremor is a common manifestation. It can be either resting or with intention, improves over improves over time. Other less common or more serious effects including visual disturbance and seizures. Glucose intolerance, increase insulin requirements. Calcineurin inhibitor impair the secretion of insulin from pancreatic islet cell, contributing to hyperglycemia. Tacrolimus appears to have stronger hyperglycemic effect than cyclosporin. Cosmetic effect, gingival hypertrophy, mostly with cyclosporin, hirsutism, and alopecia can occur. GI disturbance, these effects are usually mild and can include mm, okay, antithymocytes globulin. Antithymocyte globulin is an globulin that is derived from rabbit serum and target human T lymphocyte. It is commonly used for induction of potent immunosuppression at the time of renal transplantation. Adverse effects include serum sickness, fever, joint pain, and skin rash, leukopenia, thrombocytopenia. Azathioprine inhibits the synthesis to impair the replication of lymphocyte and is sometimes used for chronic transplant immunosuppression. Common adverse effects include bone marrow suppression and hepatotoxicity. Mycophenolate formulation, mycophenolate mofetil, mycophenolate sodium are commonly used for chronic transplant immunosuppression. These drugs are known for causing GI disturbance, nausea, diarrhea, and bone marrow suppression. Low dose prednisolone is commonly used for chronic transplant immunosuppression. Main adverse effects are many and include glucose intolerance and hypertension. However, tremor, renal insufficiency, hyperkalemia are not typical. Okay. No, acetylcholine for MG, myasthenia gravis. This child is less than 12 months and has acute onset poor feeding. This child is less than 12 months, has acute onset poor feeding with hypotonia, weakness, and cranial nerve dysfunction. Hypotonia, weakness, and cranial nerve dysfunction. Decreased eye movement in the setting of normal lab evaluation. In the setting of normal lab evaluation, no fever, decreased bowel movements. These findings are highly suspicious for infant botulism patient. Pathogenesis of infant botulism involves ingestion of Clostridium botulinum spore that germinate in the immature digestive tract and produce toxin in situ. Ingestion of honey is implicated and is approximately 15% of cases. A definitive exposure history is often absent as seen in this patient. The neurotoxin inhibits presynaptic acetylcholine release into the neuromuscular junction, affecting the following: autonomic nervous system, somatic nervous system. Autonomic nervous system involvement of autonomic smooth muscle cause hyperactive bowel and constipation, decrease bowel movement frequency, which is often the first symptom. Decreased salivation, dry oral mucosa can occur. Somatic nervous system. Muscle innervated by cranial nerves are affected first, causing oculovalvar weakness, absent gag reflex, ptosis, ophthalmoplegia. Muscle weakness, post-suck feeding may progress to descending paralysis with symmetric weakness and hypotonia weakness can rapidly progress to respiratory failure diaphragmatic paralysis. Infant botulism is usually diagnosed clinically and treated promptly with antitoxin therapy. Botulism immunoglobulin while awaiting supportive electromyography and confirmatory testing Clostridium botulinum spore or toxin assay from the stool. Botulinum antitoxin binds circulating neurotoxin, preventing symptom progression cannot reverse paralysis, which can take months to improve. Okay. Okay, this patient has a history of recurrent infection now, has epiglottitis due to Haemophilus influenzae type B infection in a fully immunized child. Infection with these bacterium is concerning for humoral immunodeficiency such as X-linked agammaglobulinemia or Bruton agammaglobulinemia. A defect in Bruton kinase prevents B cell. A defect in Bruton kinase prevents B cell from maturing and exiting the bone marrow, which results in low level of circulating plasma cell, decreased antibody production. Patients with X-linked agammaglobulinemia are predisposed to recurrent sinopulmonary infection, acute otitis media, pneumonia by encapsulated bacteria, Streptococcus pneumoniae, and Haemophilus influenzae type B. Because antibody opsonization is required for phagocytosis, gastrointestinal and enteroviral infections are common. Characteristics: lab finding in X-linked agammaglobulinemia include low levels of all immunoglobulin as well as deficient antibody response to vaccine. As seen here, flow cytometry of the peripheral blood is performed to determine the affected lymphocyte subpopulation and shows markedly reduced CD19 B cell in patients with X-linked agammaglobulinemia. Genetic testing confirms the diagnosis. Lifelong immunoglobulin replacement therapy reduces the rate of severity of infection. Okay, this patient with cystic fibrosis, nausea, pre-syncope associated with hyperthermia, tachypnea while playing soccer, suggesting an exertional heat illness. An exertional, although exertional heat stroke may present in a similar manner in the absence of CNS dysfunction. In a patient suggests heat exertion. So CNS dysfunction is heat stroke, and without CNS finding is heat exhaustion. Okay, heat exhaustion typically occurs after prolonged exercise, soccer in high ambient temperature, particularly in the setting of high humidity, which limits evaporate cooling from sweat. Like other heat-related illness, exhaustion risk factor includes older age, obesity, poor physical fitness. Infections are common in cystic fibrosis and certain medication anticholinergic. In addition, cystic fibrosis may predispose patients to heat-related illness due to higher rates of sodium and chloride in sweat. Heat exhaustion is characterized by hyperthermia. Typically, the patient's temperature is moderately elevated because is usually more than 40 degrees Celsius, 104 degree Fahrenheit. Common manifestation of heat exhaustion include weakness, dizziness, profuse sweating, headache, nausea and vomiting. Tachycardia and tachypnea are common. Tachycardia, tachypnea are common, and hypotension may occur. Unlike exertional heat stroke, mentation remains normal. Management include cooling the patient, air conditioning, cold water shower, oral hydration with chilled salt containing fluid should be encouraged due to fluid and sodium losses that occur with sweating. Okay.
27, yeah, 27 to this present.
This is cyanide poisoning. Do you want me to read the explanation?
Yes, please.
This patient with prolonged house this patient with prolonged house fire exposure likely has cyanide poisoning. Cyanide is a toxin released from the combustion of common household common household items like plastics, polyurethane mattress both carbon that contain both carbon and nitrogen. Cyanide inhibits oxidative phosphorylation, halting aerobic metabolism and forcing mm, forcing forcing a switch to anaerobic metabolism that results in lactic acidosis pH 7.15, lactic acid 25. Because tissue cannot effectively use oxygen, venous blood remains saturated with oxygen and appears bright red, causing red colored skin. Early acute toxicity causes cardiorespiratory stimulation, tachycardia, tachypnea, but cardiovascular collapse rapidly occurs unless treatment is administered. Cyanide poisoning must be empirically treated because serum cyanide levels cannot be measured. Serum cyanide level cannot be measured quickly. Hydroxycobalamin, the preferred treatment that binds to intracellular cyanide and forms cyanocobalamin, which can be renally excreted. Sodium thiosulfate, which acts as a sulfur donor that detoxifies cyanide to thiocyanate and is sometimes administered with hydroxycobalamin. In addition, treatment with 100% oxygen is continued to maximize oxygen delivery to tissue to treat concomitant carbon monoxide poisoning, and a common result of house fire exposure typically associated with elevated carboxyhemoglobin level. Is it actually? These patients' rash and multi-system symptoms suggest SLE. Common manifestation, common presenting symptoms include arthalgia, a photosensitive arthalgia, a photosensitive rash on sun-exposed skin, photosensitive rash on sun-exposed skin, and constitutional symptom flu-like illness. Other manifestation in this patient include hematologic abnormalities, thrombocytopenia, anemia, leukopenia, lymphadenopathy, splenomegaly, hypertension, likely from nephritis, and a common early form of SLE, a pathologic or diastolic murmur, possibly reflecting non-bacterial sterile endocarditis from the valvular platelet in the setting with multiple concerning symptoms and signs and symptoms of SLE. Serologic testing is appropriate and begins with an antinuclear antibody assay, which is highly sensitive for the diagnosis. However, it has low specificity and should not be performed in patients with isolated non-specific symptoms. Fatigue. Positive results should be followed by SLE-specific confirmatory tests. Anti-double standard antibody. Okay. It looks like CVID. Okay. If there is like a multiple infection like sinusitis, pneumonia, otitis media, and admitted for multiple times, think about either Bruton or CVID. And if there is nothing about Bruton and Bruton for babies. This patient is 35-year-old, so looks like it is CVID. This patient has recurrent sinopulmonary infection. This patient has recurrent sinopulmonary infection and chronic lung disease, findings suggestive of immunoglobulin deficiency disorder. Symptom onset in young adulthood. Symptom onset in young adulthood. Age. Symptom onset in young adulthood. Age 20 to 40 and is characteristics of common variable immunodeficiency. The disease is a primary humoral immunodeficiency in which antibody production is decreased because B cell cannot differentiate into plasma cell. The most common initial manifestation of CVID include acute and chronic rhinosinusitis as seen on these patients' imaging. Patients may subsequently develop progressive cough and dyspnea due to restrictive or obstructive lung disease. Mechanism for chronic lung disease include the following: immune-mediated ILD resulting in pulmonary fibrosis and scarring, bronchiectasis, dilated thickened airways due to frequent infection and inflammation, and other manifestations can include chronic gastrointestinal, autoimmune disorder, and atopic disease. The next step in evaluation of humoral immunodeficiency is a quantitative immunoglobulin level. Patients with CVID, um, patients with CVID with patients with CVID have low immunoglobulin in combination with low IgM or IgA. Antibody response antibody response to vaccine are also low in CVID, but leukocyte is generally normal. Treatment is immunoglobulin replacement therapy, and management is chronic lung disease. Okay. Alpha 1 antitrypsin deficiency is characterized by tissue damage in the lungs and liver. The sinuses are not involved. CT scan would reveal emphysematous changes, large air space, rather than fibrosis in the lower lung. Sputum culture for acid fast bacilli is diagnostic for mycoactive tuberculosis, which can cause chronic pulmonary infection, but very rarely affects the sinus. Classic X-ray findings of pulmonary TB include consolidation, cavitation, hilar adenopathy, and pleural effusion. Okay. He has granuloma. There is only one where there is granuloma. Only one primary immunodeficiency disease there where there is granuloma. Yes, this patient with abdominal pain, diarrhea, and ovarian skin tax has signs of chronic intestinal inflammation or histology cryptitis distorted crypt architecture, findings suggestive of inflammatory bowel disease, lab markers of lab markers of inflammation, leukocytosis, thrombocytosis, and a positive hemoccult with associated microcytic anemia supports a diagnosis. Onset of inflammatory bowel disease in children aged less than 5 warrants consideration of an underlying genetic defect. In this case, the patient has also a severe recurrent infection. A maternal uncle who died from infection in infancy and intestinal granuloma on histology. These history suggests of IBD-associated chronic granulomatous disease. IBD-associated chronic granulomatous disease is most likely the diagnosis. CGD is usually CGD is usually due to X-linked recessive mutation in NADPH oxidase, an enzyme responsible for neutrophil. CGD is an X-linked recessive mutation in NADPH oxidase, an enzyme responsible for neutrophil superoxide formation, respiratory burst, without the production of reactive oxygen species. Patients with CGD have impaired phagocytic intracellular killing and are predisposed to recurrent infection, pneumonia, cellulitis, osteomyelitis, classically by catalase positive organism. Patients also have impaired ability to degrade the inflammatory cytokines, which predispose them to inflammatory conditions, IBD, diffuse granuloma formation, particularly in the gastrointestinal and the genitourinary tract. In CGD-associated IBD, pigment-laden histiocytes are characteristically seen on histology and represent liposuction accumulation due to impaired lipolytic activity. Diagnosis of CGD is confirmed by measuring oxidative burst with dihydrorhamine testing, which uses dihydrorhamine derivative that fluoresces green when oxidized but remain colorless when oxidative burst is impaired. Next,
Think
Wait, uh, there is two important finding in here. One is eosinophil count. Eosinophil count is high, neutrophil is low. So eosinophilia and low neutrophil. Shediac Higashi is not like it can cause neutropenia, but eosinophilia is not same in Shediac Higashi syndrome. And there is oculocutaneous albinism in Shediac Higashi.
Famous articles. Okay.
And okay, so it is hyper IgE syndrome or JOPS syndrome.
Oh, job.
This patient has chronic eczema, recurrent abscesses, eosinophilia, chronic eczema, recurrent abscesses, and eosinophilia finding consistent with hyper IgE syndrome. An autosomal dominant primary immunodeficiency is characterized by defective T helper cell type, defective T helper cell type 17, which normally promotes neutrophil proliferation and chemotaxis to the site of the infection. Impaired neutrophil response predispose patients with hyper IgE to recurrent infection. Cold abscesses which lacks signs of inflammation. Cold abscesses which lacks signs of inflammation. No erythema or tenderness are characteristics and most likely due to Staph aureus and Candida albicans acid in this patient. Recurrent sinopulmonary infection are common and patients tend to be afebrile and well appearing. Patients with hyper IgE syndrome also have chronic severe atopic dermatitis, which is often the first manifestation of the disease, occurs in the first few weeks of life. The rash is extremely itchy and lichenified patches can develop, although non-specific elevated IgE and eosinophilia are characteristic lab finding in hyper IgE syndrome as seen in this patient. The total white blood count is usually normal even during infection and when leukocytes is expected. Diagnosis is confirmed by molecular genetic testing. Okay. Shediac Higashi syndrome mm, is a lysosomal trafficking disorder. Lysosomal trafficking disorder that presents in young children with recurrent infection, staph, strep, and oculocutaneous albinism. Neutropenia is expected and eosinophilia is not seen. Myeloperoxidase deficiency characterized by defective killing by neutrophil which leads to recurrent infection. However, eosinophilia is not associated with this condition. Wiskott-Aldrich syndrome is due to cytoskeletal defect in leukocytes and platelet. When present with recurrent infection and atopic dermatitis, however, microthrombocytopenia and bruising would be present and are not seen in this patient. Okay, yes. Hyper IgE syndrome or JOB syndrome, it is autosomal dominant. Defective JAK-STAT signaling pathway, impaired T helper 17, decreased neutrophil proliferation or chemotaxis, decreased neutrophil proliferation and chemotaxis, severe chronic eczema, non-inflammatory cold abscesses, Staphylococcus, Candida, recurrent sinopulmonary infections, dysmorphic faces, a broad nose, a prominent forehead, and retained primary teeth. Increase IgE level, increase eosinophilia, normal leukocyte count, decreased T helper abundance, supportive care, antibiotic prophylaxis, and treatment. Okay.
Progressive.
Okay. This patient's initial symptom gradual headache, sleep difficulty. Initial symptom gradual headache, sleep difficulty, difficulty with exertion, likely due to acute mountain sickness. The development of drowsiness suggests progression to high altitude cerebral edema. Hickey, a rare life-threatening emergency. High altitude illness results from abrupt ascent to high altitude without acclimatization. Altered mental status and high altitude cerebral edema share the same pathophysiology, which is believed to involve hypoxia-induced low PaO2 cerebral vasodilation causing capillary leakage and eventually cerebral edema. Many patients whose condition progress to high altitude cerebral edema also have evidence of high altitude pulmonary illness. Acute mountain sickness occurs within 24 hours of arrival at high altitude, involves relatively mild symptoms, fatigue, headache, decrease, disturbed sleep. It is common and generally resolves within a few days, with or without treatment. Oxygen acetazolamide. High altitude cerebral edema can be viewed as as end organ altered mental status, generally occurring 12 hours to 3 days after altered mental status onset. The development of encephalopathic symptoms, drowsiness, confusion, ataxia, signals this progression. If left untreated, coma or death due to brain herniation can occur within 24 hours. High altitude cerebral edema is clinically treatment is aided by dexamethasone, which can decrease cerebral swelling and is administered at the sign of first symptom. Definitive management requires immediate descent to the lower altitude. Okay. High altitude illness reduce PiO2 at high altitude. Altered mental status, happy and hacky. Altered mental status is headache, fatigue, nausea. High altitude cerebral edema, there is low PaO2, arterial oxygen is low, increased cerebral edema. Lethargy, confusion, ataxia, high altitude pulmonary edema, uneven, hypoxic vasoconstriction, dyspnea, cough with or without hemoptysis, and respiratory distress. Supplemental oxygen acetazolamide for altered mental status. Sorry, acetazolamide for acute mountain sickness, dexamethasone for achy, and descend to the lower altitude. Definitive treatment for all high altitude. Okay.